Hi there, my valued and esteemed and highly treasured viewers and listeners, and welcome back to my channel and to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and profession. I am the founder of Progressive Pharmacotherapy Consultants, the virtual clinical pharmacy institute where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. We seek to remain your premier source of crucial tips for high-impact clinical pharmacotherapy services. So I would urge you to sit back and spare me part of your precious time as I share tips that would lead to high-impact pharmacotherapy in your line of duty. So welcome to part 4 of our pharmacotherapy MCQs. So the first question is, which of the following is true regarding IV calcium gluconate and IV calcium chloride? Is it calcium gluconate provides 4.65 milliequivalents per gram of elemental calcium, while calcium chloride provides 13.6, or is it calcium gluconate 1 gram and calcium chloride 1 gram both provide 4.65 milliequivalents per gram of elemental calcium, or is it calcium gluconate provides 13.6 milliequivalents per gram of elemental calcium, while calcium chloride provides 4.65 milliequivalents per gram of elemental calcium, or is it D, calcium gluconate and 1 gram of both calcium gluconate and calcium chloride provide 13.6 milliequivalents each per gram of elemental calcium? I'll give you 10 seconds to choose the correct answer. In my opinion, the correct answer is A, and the reason behind is that 1 gram of calcium chloride in a 10 ml ampule contains 13.6 milliequivalents of elemental calcium according to the labeling, and a gram of calcium gluconate in a 10 ml ampule according to the labeling contains 4.65 milliequivalents of elemental calcium. Let's move to the next question, which reads, there were a total of 510 cases of syphilis with 106 reported new cases of syphilis in a county called ZWB in 2015. Now the population in that county was 410,200 people. So my question to you is, what is incidence proportion of syphilis in 2015 in county ZWB? What was the incidence in that population? Was it 0.026, 0.153, 0.051, or 0.015? I'll give you 10 seconds to compute the value. So the correct answer is A, and I'll give you 5 seconds to look at how I arrived at that answer. Now, in case you need more time to understand it, I would advise you to watch the video one more time. So, same county, same population. The question this time round is, what is the incidence rate of syphilis, or what was it in 2015 in this county? Was it 2.6 per 10,000 person years? Was it 2.3? Or was it 2 cases per 10,000 person years? Or was it 3.2 per 10,000 person years? I'll give you 10 seconds to do the computation. So the correct answer is A, and I'll give you another 6 seconds to look at how I calculated to arrive at that answer. So the next question reads, which of the following beta blockers is not proven to reduce mortality in patients with systolic congestive heart failure? Is it Basoprolone? Is it Nadolol? Is it Carvedilol? Or Metoprolol succinate? I'll give you 10 seconds to choose the correct answer. So in my opinion, choice B, Nadolol, is the correct answer. Now, Nadolol is not proven to reduce mortality or to produce mortality benefits in patients with systolic CHF. The efficacy of Nadolol in heart failure has not been determined or studied. Now, for patients taking Nadolol, it should be used with caution, especially in the compensated heart failure cases, and they should be monitored closely for any worsening of their condition. Bisoprolol, Carvedilol, and sustained release metoprolol succinate are the beta blockers that have been proven to reduce mortality in patients in this category. Now remember, it's metoprolol succinate, not tartrate. Yeah, the succinate is superior in this particular category of patients. Yeah, so remember, these 3 beta blockers have been proven to be effective in reducing the risk of deaths in patients with chronic HFrEF, according to many publications out there. Now, other beta blockers were found to be less effective. Pusindolol, for example, did not exhibit uniform effectiveness across different populations. It registered mixed results. So those studies showed actually that metoprolol tartrate, not succinate tartrate, was found to be less effective in the heart failure trials. So that makes B our correct choice. So the next question reads, TM is a 78-year-old woman with a history of hypertension, hypercholesterolemia, and arthritis, and she was admitted for paroxysmal AFib. While in hospital, she was placed on diltiazem drip and eventually converted to an oral diltiazem at a dose of 240 milligrams sustained release once a day. Home medications include simvastatin 40 milligrams orally once a day at night, hydrochlorothiazide 25 milligrams orally daily, lisinopril 20 milligrams orally once a day, and acetaminophen or paracetamol to relieve pain. Now her LDL cholesterol is currently 100. So what would be the most appropriate change to make on her therapy? I'll give you 10 seconds to make a choice. To increase the simvastatin to 80 milligrams orally at night, or would you keep simvastatin at 40 milligrams daily, Or would you change simvastatin 40 to atorvastatin 40 milligrams at night? Or would you swap simvastatin with lovastatin 20 milligrams orally at night? In my opinion, choice C would be the best option. Now, A is incorrect. Diltiazem, which she's taking for her AFib, has a major drug-drug interaction with simvastatin, so I would not retain it at all. Now, diltiazem is a CYP3A4 inhibitor, and since simvastatin is metabolized by the same CYP enzyme group, its levels would build up. So you risk having toxicity, an overdose of diltiazem, simvastatin, and that may result in myopathy and even rhabdomyolysis in extreme cases. So I would knock it off the regimen. It is recommended to switch to a non-CYP3A4 inhibitor, and examples include pitavastatin, pravastatin, or rosuvastatin, and even atorvastatin would do. Now, if simvastatin is to be kept, the dose should not exceed 10 milligrams per day, but I would opt to knock it off. Now, the same drug-drug interaction occurs with lovastatin, so that makes choice D inappropriate. And if you are to use it at all, the recommendation is not to exceed a total dose of 20 milligrams of lovastatin per day. Now, given the current options, the best choice would be 40 milligrams of atorvastatin daily at night. Now, our next question reads, what is the optimal duration of antibiotic therapy for HAP and VAP? Is it 5 days, 7 days, 10 days, or 2 weeks? I'll give you 10 seconds to make a wise decision. So, in my opinion, B is the correct answer. Remember, when we used 7 as opposed to 2 weeks, we would exert less selection pressure and would drive resistance to a smaller extent. Less collateral damage would occur, and fewer superbugs would emerge. From an AMS perspective, the answer B, in my opinion, is correct, because shorter courses of antibiotic, like 7 days, are associated with less exposure and less antimicrobial resistance. This would reduce costs and side effects as well, and the benefits of short-term therapy would be kind of positive, in my opinion, without necessarily compromising the clinical outcomes. So I would go for 7 days as opposed to 10 or 14 days. Studies have shown that for VAP and HAP, outcomes don't differ much. So in our next question, JFA is a 62-year-old man who has never received the zoster vaccine. When he was 57, he had an episode of herpes zoster, and he seeks to know from you if he's a candidate for a zoster vaccine. So which of the following statements is true concerning JFA's query? Should you answer to him B, no, you are not a candidate for zoster vaccine since you already had a bout of herpes zoster and therefore have immunity to it? Or should the answer be yes, he is still a candidate for the zoster vaccine regardless of prior episodes of herpes zoster? Or should the answer be no, he isn't a candidate since it is recommended for patients who are 65 years or above? Or should the answer be no, he is not a candidate since he is not only, it's only indicated in patients who are above the age of 60. So I'll give you 10 seconds to make a rational decision. Option B is the correct answer. Now, a single dose of zoster vaccine is recommended for all adults 60 years or older, regardless of whether they report prior episodes of herpes zoster or not. That's answer A is wrong. Now, although the second and the third episode of herpes zoster can occur, the annual incidence of recurrence is unknown. And although the FDA advises the administration of these vaccines for individuals 50 or older, the ACIP recommends that vaccination begins at 60. Yeah, so both answers C and D are incorrect. That leaves us with B as the most appropriate choice. Let's move to the next question, which says WOA is a 77-year-old woman with a history of hypertension. She has been admitted for ischemic stroke. What would be the appropriate pharmacotherapy recommendation upon her discharge? Would you discharge her on atorvastatin 20 milligrams at night, or would you opt for pitavastatin 1 milligram at night, or would you go for high intensity atorvastatin 80 milligrams at night, or would you opt for 20 milligrams of lovastatin at night? I'll give you 10 seconds to make the correct choice. In our opinion, C is the correct answer. Now, a stroke falls under the category of clinical ASCVD, the atherosclerotic cardiovascular diseases, which also includes acute coronary syndrome, history of MI, stable or unstable angina, coronary or other arterial revascularization, strokes, TIAs, peripheral arterial disease. Yeah, all those fall under that umbrella. Now, patients with clinical ASCVD are at a risk of recurrent episodes of the same and even death from the same. Our patient here is 75 years old, and such patients at this age with clinical ASCVD should receive moderate intensity statin. But there is also the ATP4, that's the Adult Treatment Panel 4, which acknowledges that older patients in the corresponding randomized control studies that were done were likely to be healthier than those in the general population. So treatment can be individualized. Now, given the options above, high intensity statin is the most appropriate option for this particular patient to avert disaster in future. So the decision to start atorvastatin at 80 milligrams instead of 40 is based on their recommendation to down titrate in case the patient does not tolerate the 80 well, as opposed to up titrating, which is in accordance with the ideal trial. So I would feel more comfortable starting on 80, and in case the patient does not tolerate it, I would lower the dose to 40. Now 20 milligrams of atorvastatin would be on the lower side. 1 milligram of pitavastatin would also be very mild, so would be the lovastatin. So answer C, in my opinion, is the best option. Let's move to the next question, which reads, due to contamination of water supply in a small town, there were several outbreaks of gastroenteritis. 1,650 people drank the water supply, of which only 250 had GE, and 1,540 people drank the bottled water, of which 3 people had GE. So I would like to task you to construct a contingency table, and then my question to you is, what is the odds ratio and what is the relative risk? So I'll give you 10 seconds to work on the 3 tasks before I display my answers. Would the odds ratio be 17.85 with an RR of 15.15, or would it be 91.5 and 77.78, or would it be 8.7 and 7.83, or would it be 0.21 and 0.19? So in my opinion, B answer, and I'll give you another 6 seconds to look at that slide and see how I arrived at those 2 answers. To the next question. JKT is a 75-year-old woman with a history of systolic heart failure who presents to your A&E with a 5-day history of progressive worsening of her shortness of breath. Now her PBN, so her BNP is 28,869 picograms per ml. Her chest x-ray shows a cardiomegaly with pulmonary vascular congestion, and she is atelectic in the mid left lung. There is bilateral effusion, but she reports to you that there are no chills and you don't notice any fevers. Her 2 average blood pressure readings are 135 systolic, 92 diastolic. The heart rate is 72, and she is currently on enalapril 20 milligrams daily, carvedilol 6.25 orally twice a day. So which of the following would be the immediate course of action in the management of JKT? Will it be Lasix or furosemide 40 milligrams IV twice daily as we monitor fluid status? Would you increase the enalapril dose to 40 milligrams BD orally? Would you increase the carvedilol to 25 milligrams orally twice a day? Or would you infuse normal saline at the rate of 100 ml per hour? I'll give you 10 seconds to make a choice. In my opinion, A would be the correct answer. Now, initiating furosemide IV would be the immediate course of action in order to improve the symptoms of fluid retention. Fluid status would be closely monitored. Now, normal saline would not be administered. It would only worsen the breathing because this patient requires fluid restriction. And it should be restricted to around 1.5 to 2 liters daily to reduce the congestive symptoms. Now, for enalapril in option B, the maximum dose should be 20 milligrams BD for the treatment of heart failure. So 40 would be an overdose, and carvedilol would not be increased until after we have stabilized the patient and the IV diuretics have been stopped. And we should also have gotten rid of vasodilators and any ionotropes before introducing carvedilol. So that would be my take. Option A would be the correct answer. So same patient, average BP is 135/92, heart rate 72, same medication, and 4 days later she is on a maximum furosemide dose of 120 milligrams IV twice a day, and you've also added metolazone 10 milligrams orally once a day. Now, despite this maxing the diuretics, her chest x-ray still shows pulmonary edema. Her urine output has decreased, and now she's desaturated. She requires oxygen. So and her creatinine clearance has gone up. The kidneys are taking a hit. Clearance is now 3. So which of the following medications would be the most appropriate to initiate at this stage now that you've maxed out on the diuretics? Would you infuse sodium nitroprusside, butamine, nitroglycerin, or nesiritide? I'll give you 10 seconds to choose. So personally, I'd opt for nitroglycerin, which would be the most appropriate to initiate once we've maxed the diuretics. It helps reduce pulmonary congestion. There is also no dosage adjustment provided in renal impairment. Sodium nitroprusside can also dilate the pulmonary vasculature. However, in patients with renal impairment, there is a risk of toxicity. The thiocyanate thing, it could accumulate and endanger the life of this patient. Now, Nesiretide has a longer half-life compared to nitroglycerin and sodium nitroprusside, and it may result in adverse drug reactions occurring when we administer it. There would be greater levels of hypotension. Now, studies have also indicated that patients may be at a risk of worsening renal function and increased mortality when we opt for Nesiretide. A recent meta-analysis showed that there was no significant increase in mortality when compared to placebo, and there was no increased risk in mortality in those treated with Nesiretide. However, it is also associated with an increased risk of cardiovascular adverse events like bradycardia and hypotension, and those would make me uncomfortable to use it. Now, dobutamine would not be appropriate in this case. It would be used as a short-term management in those with cardiac decompensation in order to maintain perfusion and to preserve end organ performance, especially in those with cardiogenic shock. Now, bridge therapy in those with stage D heart failure or who are unresponsive to guidance-directed medical therapy and device therapy awaiting heart transplant or mechanical circulatory support can also benefit from this. So, after factoring all those and bearing in mind that guidelines have also stated that intermittent IV positive inotropic therapy has no proven value in patients, especially in stage C of heart failure, I would shy away from dobutamine. So that leaves me with the nitroglycerin as a good choice. Now, same patient. Okay. An echogram was ordered. Her ejection fraction was estimated in the range of 25 to 30. And because of your interventions, JKT feels better. Her shortness of breath has improved. Her average BP is 142 systolic, 92 diastolic. The heart rate is above 72 still. And at this stage, you've stopped all the diuretics. And she's hemodynamically stable. So what would be the next best appropriate course of action? Would you increase the carvedilol to 12.5 orally twice a day? Would you increase the enalapril to 40 milligrams once a day orally? Would you add to the treatment 0.25 milligrams of digoxin once a day orally? Or would you change the carvedilol 3.25 to metoprolol tartrate 25 milligrams orally twice a day? I'll give you 10 seconds to make a decision. I would increase her carvedilol dose to 12.5 BD. That would be my next course of action. Since all the diuretics have been stopped, she's hemodynamically stable, initiating a beta blocker would be appropriate, and the dose would be gradually increased bi-weekly to the highest dose tolerable by this patient. Now, she would have to be monitored for congestive signs and symptoms of heart failure. Now, I would not add digoxin, even though digoxin can improve symptoms in mild to moderate cases of heart failure. Long-term treatment has no effect on mortality, and it has the potential to reduce hospitalizations due to heart failure though. Now, carvedilol would not be swapped with metoprolol tartrate, since metoprolol tartrate has been found to be less effective in heart failure patients. And I would not increase enalapril doses above 20. 40 would be a gross overdose, so that makes choice B inappropriate. In the next question, which of the following does the following clause most accurately define? So the clause is the proportion of a population of people who have a particular disease at a specified point in time or over a specific period. What does it define? Does it define incidence rate, prevalence rate, mortality rate, or relative risk? I'll give you a few seconds to decide. So in my opinion, it defines prevalence rate, and below is the explanation as to why. So I'll give you another 6 seconds to read through. So in our next question, JJM is an 86-year-old woman who weighs 282 pounds and is 5 feet 10. She has a past medical history of hypertension, upper GI bleed, osteoarthritis, renal failure stage 4, and her congestive heart failure with preserved ejection fraction. Her current BP is 142 systolic, 92 diastolic, and she has an A1C of 9.3. Her current medication include metformin, 500 milligrams BD orally, and insulin glargine, 20 units administered subcutaneously at bedtime to manage her diabetes mellitus. Atorvastatin, 20 milligrams taken at night to manage the hyperlipidemia. She's also on lisinopril, 5 milligrams orally once a day, diltiazem 360 milligrams orally once a day, pantoprazole 40 milligrams, which was given for the GI bleed, orally twice a day, and she takes acetaminophen, a gram 4 times daily to relieve pain. So which of the following would be the most appropriate option for the management of her type 2 diabetes mellitus? B. Discontinue metformin and add pioglitazone, 30 milligrams orally once a day. Would you discontinue metformin and add empagliflozin, 10 milligrams orally once a day? Or would you discontinue metformin and introduce exenatide, 2 milligrams subcutaneously once weekly every Monday? Or would you discontinue metformin and increase the insulin glargine to 30 units at night and introduce the bolus insulin of 5 units of Lispro subcutaneously thrice daily at meal time. I'll give you 10 seconds to make a rational decision. Choice in this case would be D. I would like to remind us that this is a patient with congestive heart failure. Her EGFR is 15 to 30. She's stage 4 and she's had a GI bleed. Now, pioglitazone in choice A would be the wrong switch. It is not a good option because it can exacerbate her congestive heart failure, and it carries a black box warning for the same, so no off option A. Now, empagliflozin is not a good option since it's contraindicated in patients with the estimated glomerular filtration rates below 30. Remember, our patient is in the 15 to 30 range, so it would be hazardous. Exenatide is not contraindicated in patients with the creatinine clearance below 30, but it's not a good option for our patient because there is a history of a GI bleed, which is a precaution for the use of this drug, since exenatide would tend to slow the gastric emptying. I would be reluctant to use it. Now, increasing her basal insulin and adding a low dose acting insulin would be an appropriate option in my case, in my opinion. So I would opt, or I would settle for solution D. So, same patient. Now, her current medication is the same, but this time my question to you is, what should her goal A1C be? Should it be below 6.5, below 7.5, below 8, or below 8.5? I'll give you 10 seconds to choose. So in my opinion, C would be the correct answer. Yeah, it should be below 8. She has multiple chronic comorbidities such as hypertension, chronic kidney disease stage 4, osteoarthritis, heart failure, and above all, she's elderly. Now, she doesn't have end-stage chronic illnesses that meet the criteria of below 6, and the below 7.5 goal solely applies due to her age, which is above 65. Now, the below 7 goal is meant for non-elderly adults as per the ADA guidelines. Now, the below 6.5 goal is for healthy non-elderly patients according to the AACE/ACE guidelines. So I would be more comfortable with choice C. So my dear listener, that brings us to the end of part 4 of our pharmacotherapy MCQs, and I hope you gleaned a lot of useful tips from this session that will help you deliver effective and safe pharmacotherapy to your esteemed clients. Now, if this video helped you in any way, I would like to remind you to give it a thumbs up and to subscribe to my YouTube channel. I would like to promise you and assure you that the best is yet to come. And I'm grateful, and I would like to thank you for viewing, for listening, and I appreciate your partnership and your kind support. I hope to interact with you in part 5 and subsequent parts of this series. Thank you for watching and for listening.